Hello, everyone. Thank you for coming. We're just waiting a few more minutes and then we'll get started.
Okay, so in the interest of time, I think I'll just start now, because we have quite a lot to go through today. So hi everyone, I'm Ziki, I'm a fourth year medical student at GTC, and today I'll be going through the motor topic in the second year neuro syllabus, and it's actually quite an extensive topic, so there's a lot to go through. And there's a chance that we may not be able to finish going through everything, but you'll get the slides if you fill in the feedback at the end. And I think it's quite like information overload because I think a lot of the slides just contain lots of information because it's quite, as I said, it's quite a big topic and a lot of things you just have to go back and look at them again on your own and commit them to memory. So these are the topics I'll be going through. I'll try to focus a bit more on like the important points, like the important things. And there's some topics I won't cover in detail, like locomotion into neurons. Okay, so we start with upper and lower motor neurons. Oh, and sorry, if at any point, if any of you think I'm going too fast or too slow, or if you have any questions, or if what I said wasn't clear, you can just type in the chat, or you can unmute yourself, and I'll try to answer your questions. So we'll start with the upper and lower motor neurons. And first is just a quick overview. As all of you probably know, the upper and lower motor neurons, the main difference is that the upper ones, they start in the brain and they end in the spinal cord, whereas the lower motor neurons start in the spinal cord and they end in like the muscles or glands which they innervate. And that's where, for example, they synapse with the motor end plate and cause contraction of the muscle. And therefore, the main neurotransmitter for lower motor neurons is acetylcholine, which is the main neurotransmitter of the peripheral nervous system. Whereas for upper motor neurons, they use glutamate. And so the difference in terms of like function is that the upper motor neurons, they are involved in voluntary motor responses. So they're not involved in reflex responses. Whereas because if you think about it, like the reflex, the efferent doesn't go to the brain. So they're not involved in reflexes, whereas the lower motor neurons are involved in both because they innervate the muscles and they form a two neuron circuit. So in terms of the lesions, I think this is quite important to know, like what are the different effects of like upper versus lower motor neuron lesions. And these are some of the categories that I came up with and that would be important to know. So can any of you type in the chat? Like you can choose any of the categories and just type what you think would be the difference between upper or lower motor neuron lesions. You can just choose one and just type in the chat. If no one types anything, we'll just like we won't move. Like for example, you can think of like whether there is or isn't like muscle atrophy or there is or isn't fasciculations in each one. if someone can just choose like one of them and just say what you think is the difference. Yeah, okay. So you mean like, yeah, okay, good. So atrophy is in lower motor neuron lesion, but not in upper. That's very good. Yeah, so in the interest of time, I'll just move on. I will try not to pause for too long because we have a lot to go through. So the first and one of the most important ones to know actually is that for muscle atrophy, you'll get it in like lower motor neuron lesion because if you think about it, it makes sense because they are like innervating the muscles, whereas it's minimal within upper motor neuron lesion. And fasciculations. So fasciculations are basically like involuntary muscle twitches. And again, these are present in LMN lesions. For the tone, it's paradoxical, but it's increased with like UMN lesions. So you get spasticity or rigidity. And cloners, so you could get cloners. Cloners again means kind of like involuntary movements, but they're like rhythmic movements. And these are like normally you find it in the ankle quite typically. So ankle clonus. And you have decreased tone, so hypotonia or flaccidity in low motor neuron lesions, and that's kind of like related to the muscle atrophy. And in terms of the power, UMN lesions affect extensors. They affect extensors more in the arms, and vice versa in the legs. Whereas in LMN lesions, it just depends on like which nerve was affected and which muscle group they're innervating. And then for Babinski sign, it's positive in upper motor neuron and negative in lower motor neuron lesions. I'll talk a bit about what exactly the Babinski sign is a bit later. And then for the reflex, this is increased in upper motor neuron, decreased in lower motor neuron lesions. And then for the examples of like the sites of lesion, you don't really have to know the examples, like the two rows at the end. But these are just like for you to get an idea of like what you might see in like different conditions. So there are some conditions like ALS which can affect both like upper motor neurons, whereas like stroke is mainly like in the brain, so it's mainly affecting like upper motor neuron. And then you get some like that exclusively affect lower motor neurons. But I won't go through all of them because you don't need to know this in detail. I think it's more important to know like the first few rows where you kind of like able to differentiate between the lesions and the effects that they cause. So the Babinski sign, which we mentioned earlier, is elicited by like stroking the sole of the foot, and this is it's called the plantar reflex. And the Babinski sign is when it's abnormal. So in a normal plantar response, if you stroke the sole of the foot, the toes will go down, and that's like flexion of the toes. Whereas in an abnormal response, which is the Babinski sign, you get a fanning of the like extension and fanning of the toes upwards. It's quite important to test, quite an important test in neurological examinations because it helps you to differentiate like what kind of like whether there is a lesion and what kind of lesion it is. So as I mentioned earlier, it's an upper motor neuron lesion that causes the Babinski sign. So now we move on to the next topic, which is the muscle stretch reflex. And I would just like to start by reiterating like the different components of a reflex arc. So I think this is something that you probably already know, but just to make it like simple to know in terms of what are the different components of a muscle stretch reflex. So it's called a monosynaptic reflex arc, and the first component is the receptor, which in the muscle stretch reflex is the muscle spindle. And then you have the afferent fiber, which is like the muscle spindle afferent or like the afferent neuron. And then there's an integrating center, which is the spinal cord. And for the muscle stretch reflex, it's number 9. And then for the efferent fiber, it's alpha motor neurons. And finally, you have the effector, which is the muscle, which is the um like the action is the muscle contraction. So this is basically a summary of the components of the reflex arc. And this is when you put into like a specific example, one of the most common examples that you learn about is the patella tendon reflex. So the stimulus is like when you tap the tendon with like a tendon hammer or with like something, and then the receptor are the muscle spindles within like the muscle, which senses the stretch, and then there's an afferent pathway, which is the sensory neuron, and you have the integrating center in the spinal cord. So because it's a reflex, so it doesn't go to the brain, and then the efferent pathway. There are actually two different pathways. The one that causes the contraction is the one that innervates the quadriceps muscle, so the quadriceps contracts, and then there's a second path, efferent pathway, where you have an interneuron that inhibits the antagonist muscle. So it's like a reciprocal inhibition of the hamstring muscle, which causes like hamstring muscle to remain relaxed so that only the quadriceps contracts, and therefore causes extension and swinging forward um of the leg. And this slide I will skip. It's like the cross extensor reflex, but I think it's less important, and you can look at it in your own time. It's basically like when it's normally described when you have a painful stimulus, and then there's a withdrawal reflex that causes the body to shift its weight away from the painful stimulus. But I'll skip it for now because it's not talked about. Like it's less important, I think. So we'll talk about like the different types of muscle receptors. So the one that we mentioned earlier are the muscle spindles, and these are located within the muscles, like in the fleshy parts of the heart that like is bulging, and they're in parallel with extrafusal fibers, and they signal stretch and cause reflex contraction. On the other hand, you have Golgi tendon organs, which are, as the name suggests, they're located in the tendons at the end of the muscle, and they're in series with extrafusal fibers. And what they do is they signal tension produced by the muscle contraction, and they cause reflex inhibition and hence relaxation of the muscle. So I think it's quite important to differentiate the function of like the two different muscle, like the two main groups of muscle receptors, and together they play a role in proprioception, because like sensing and signaling like stress and stretch and tension helps with like balance and like maintaining posture, and like and they work like both of these groups of muscle receptors work with joint mechanoreceptors to maintain balance and posture. So to talk a bit about the muscle receptors themselves, I think this is less important, but I'll just go through them quickly. So the components of each spindle, you have the intrafusor muscle fibers, which are like the central part of the muscle fiber, which are non-contractile, and then you have sensory nerve fibers, which are myelinated, and they surround the non-contractile part of the muscle, and they're sensitive to the stretch of the intrafusor fiber. And finally, you have small diameter gamma motor nerve fibers, and these innervate the contractile ends of the intrafusor fibers. And this diagram kind of summarizes the different types of fibers that are involved in the muscle stretch reflex. But the part that I kind of I'm not going to talk too much in detail about is the interneurons, so the inhibitory interneurons. So there are three types of inhibitory interneurons, 1A, 1B, and ventral inhibitory neurons. So I don't think you have to know them in detail. I don't remember learning them in detail, but you just have to know, I think an important thing that you know is that the inhibitory interneurons are the ones that kind of they inhibit the antagonist muscle and cause like relaxation of the muscle, so that it does not oppose the contraction of the muscle that's contracting. So for example, in the patellar tendon reflex, which we mentioned earlier, the inhibitory interneuron is in the second efferent pathway, controlling the hamstring muscle. And because of the inhibitory effect, it allows the hamstring muscle to relax. So that is like the main function of these interneurons in the muscle stretch reflex. Okay, so now we'll talk a bit about the different types of reflexes. So can someone type in the chat like an example of a reflex other than the patellar tendon reflex? Like any reflex in the body? Yes, good. Biceps. Anyone else? Okay, I'll just move on, I think. Yeah, but you can type in the chat if you think of anything else. But how we can think about it in terms of like upper and lower limbs. So in the upper limb you have the biceps. So you have the biceps and you also have the brachioradialis and the triceps. In the lower limbs you have patella, Achilles, and plantar. So these are the main ones, but I'm not sure if the syllabus has changed or anything. I think the main ones that we had in our syllabus were the biceps, triceps, patella, and plantar, I think. Yeah, but check your syllabus to know which ones you need to know. So can someone tell me what do you think is the spinal level of the biceps reflex? You can just type in the chat what you think is the spinal level. Or you can tell me if you think it's like C or L or yeah, okay. And what about the patellar reflex? Like which level do you think it's at? Yeah, okay, good. So I'm just gonna show the table. And yeah, so biceps is C5, C6, and patella is, I think it's predominantly L4. So you're right, it's predominantly L4. But some sources say L2 to L4. So you could consider like L2 to L4, but it's predominantly L4. And then I've listed the rest as well, and you can go back and look at these and just memorize them before the exam if it's in your syllabus. And then the plantar is L5 to S1. So then I also listed like the nerve supply, which I think you probably learned in first year as well. So you probably remember like which nerves innervate which parts of the muscle. So if you think about like the muscles, then you'll know like which nerve is innervating these reflexes. It's the same as the muscles that are contracted. Okay, so we'll move on now to the descending pathways. And these are kind of talking about like the different tracts in the spinal cord. And I remember that when I was learning them, these were very confusing because the names, like some of the names sound kind of similar, and it's like confusing what like it's hard to remember like how to differentiate between them. But I'll just go through like um how they can be like grouped or categorized and how you can think of them in terms of like both anatomy and function. But I think I'll focus a bit more on function. Um, so we'll start with like medial versus lateral descending system. So medial versus lateral, these two groups are actually talking about like the anatomical location. So whether they're like medially located in this, like medially running through the spinal cord or laterally running through the spinal cord. And the importance of knowing this is because firstly, they innervate different muscle groups. And secondly, it helps you to know whether or not they decussate or like whether they're supplying like contralateral muscles or both external and contralateral muscles. So the medial descending tracts, they descend in the ventral midline columns and they end bilaterally. So meaning they innervate both external and contralateral muscles, and they end on interneurons mainly. And they supply the axial and proximal muscles. So it makes sense because if you think about it, it's like they're in the middle. So you can think about it like trunk muscles, like back muscles. And therefore they help to control posture, locomotion, and proximal components of reaching movements. And I've listed the tracts that are medial. And the lateral ones they depressate, so they innervate the contralateral muscles, and they descend in the lateral columns. They often end on alpha motor neurons, and they control distal limb muscles. So, for example, like the fingers, the hand muscles, and therefore they allow for like precision, grip and palpation. And here I've listed the lateral tracts, and now I've just like grouped them. Sorry, I've color coded them, and also listed them based on where they originate. So from the cerebral cortex begins the cortical spinal tract, and then you have the lateral as well as the anterior cortical spinal tract. So the anterior cortical spinal tract is medial, like medially located, and then those that originate in the midbrain are the rubrospinal and tactile spinal, and only one originates in the pons, which is the pontine reticular spinal, and it's also called the medial reticular spinal tract. So don't get confused, they're the same thing, like pontine or medial reticular spinal tract are the same thing. And then you have those that originate in the medulla, which are the medullary reticular spinal, which is the same as lateral reticular spinal tract. And finally, you have vestibular spinal. And you can also group them by whether they're pyramidal or extrapyramidal. So there are only two pyramidal tracts, which are cortical spine and cortical bulbar. And when I say pyramidal, it means that they run through the medullary pyramids. And that's just like a structural differentiation. So the pyramids contain the fibers of the cortical spinal and cortical bulbar tracts, whereas everything else, like all the other tracts, run outside of the pyramids. And now I'll just go through all the different tracts. And I think it's like quite a lot of information, but the main things that you need to know are number one, where they originate, number two, where they run through and where they decussate, like where they cross, and number three, where they terminate. Because that will that also helps you know like what would the effects of like lesions on these tracts be. So the first one is the cortical spinal tract, which is the main tract involved in voluntary movement. So if you don't remember anything about the cortical spinal tract, just remember that it's involved in voluntary movement. And it makes sense because it begins in the parts of the cerebral cortex that are involved in control of voluntary movement, which are the primary motor cortex, premotor cortex, and supplementary motor area, principally. So the neurons, they descend through the internal capsule, and so this has structural importance because if it gets compressed from like hemorrhagic bleed or stroke, then you'll get like internal capsule stroke, which can cause quite extensive paralysis. And then the important thing is that it divides into lateral and anterior. So the lateral ones, as I mentioned earlier, the fibers decussate, and they descend contralaterally in the lateral funiculus, and so they control like the contralateral distal limb muscle. Whereas the anterior one, they control the axial motor neurons, and they are bilateral. So they kind of like only decussate where they terminate in like the ventral horn. And the cortical bulbar tract, compared to the cortical spinal, the difference is that they, instead of ending in the spinal cord, they end in the cranial nerve motor nuclei, which are in the brainstem, and they are involved in controlling. So if you remember, like the cranial nerve nuclei, they're involved in the half motor functions. I've listed them on the right. So these are involved in head and neck muscles, and all of them, I don't think you need to know like whether they're bilateral, contralateral per se, because most of us assume that most of them are bilateral. And I've just listed the cranial nerves with motor function. So you have 3, 4, 6. So it's 3, 4, 5, 6, 7. And then like the tongue muscles, and then yeah, basically just remember like which parts are being controlled by which motor nuclei. But I think you guys have gone through this in like a separate lecture on cranial nerves. And here's a diagram that can be quite useful, but it's more of like neuroanatomy. So you will also like revise this in neuroanatomy. And now I'll just go through the 4 extrapyramidal tracts. They originate in the brainstem, and they carry the motor nerve fibers to the spinal cord, and they're mostly involved in with reflex or unconscious, like responsive movements, compared to like the cortical spinal, which is involved in like voluntary movement. So vestibulospinal tract originates from the vestibular nuclei, which receive input from the semicircular canal system. So this is you can remember it from the name because of the vestibulo in the name, and therefore it has a lot of functions in terms of like control of balance and posture, and it innervates anti-gravity muscles. So again, there's a medial and lateral, and the medial one is the fibers descend bilaterally, and it innervates the cervical and upper thoracic spine and neck muscles, whereas the lateral ones they descend ipsilaterally this time, and they innervate the back extensor and extensor motor neurons in the lumbar spine. So the medial innervates like those that are higher up, whereas lateral innervates those that are lower down. But they have like the same function. I think the most important thing for this is to remember the function. And then for reticulospinal, again you have medial and lateral. And actually reticulospinal, I think, is the one where the function is not as well understood, but the medial one facilitates voluntary movements by increasing muscle tone, whereas the lateral one inhibits voluntary movement by reducing muscle tone. Sorry, I'm going through these quite quickly, but because there are more important things to talk about later on. So for these you can like revise in your own or like read them again in your own time. And now we move on to the cerebrospinal tract, which originates in the red nucleus. And the fibers decollate in the red nucleus. So all of it is like contralateral innervation. Yeah. And they supply the upper limb flexors and trunk flexors. So when they're stimulated, they cause upper limb flexion, and when they're inhibited, they cause upper limb extension. So this is important in the decorticate versus decerebrate posturing, which I'll talk a bit about if we have time. And then finally, you have the tactospinal, which arises in the superior colliculus. So if you remember, the superior colliculus is in the midbrain, and its function is mostly like visual input, but also auditory and somatosensory input, because it's involved in like, if you remember your your vision and audition lectures, it's involved in that. And therefore the tactospinal tract, it coordinates head and neck movements in response to visual, auditory, or somatosensory stimuli. Yeah, I'll skip this. So in terms of like lesions, as I mentioned, when you know the anatomy, it's quite logical. The lesions, like the effect of the lesions, become quite logical. So, if you have, for example, injuries to the pyramidal tract above the medulla, that's before they decussate, then you tend to get contralateral hemiparesis or hemiplegia. Whereas if it's at if you get a lesion that's below the level of decussation in the lower medulla or in the spinal cord or in the peripheral nerve, then you get an ipsilateral hemiparesis or hemiplegia. So just to explain these different terms, like hemiparesis and hemiplegia, which like sound quite confusing. So hemiparesis is weakness of one side of the body. So paresis is like weakness, and the hemi is like half. And hemiplegia means complete paralysis. So it just depends on the difference between those two, just depends on the extent of damage. Like it can be at the same location, but hemiplegia is when you have like more extensive damage, or it's like completely like the cord is completely cut at that point, then you will get complete paralysis. And then you can have like you also have more severe effects if, for example, the lesion is higher up. You can get paraplegia, which is complete paralysis below the waist, or quadriplegia or tetraplegia, which means complete paralysis below the neck. And that just depends on like the level of the lesion, like whether it's for example, like a cervical spine injury, or whether it's a thoracic spine injury, or like a lumbar spine injury. So it just depends on the level of the lesion. Does anyone have any questions? You can type in the chat. Okay. But I'll keep moving in the interest of time, but if you have any questions, feel free to just ask them at any point. And for this, that I mentioned earlier about decerebrate versus decorticate posturing, it's related to which tract or like which which tracts are damaged by which lesions. So remember we said that the cerebrospinal tract, it originates in the red nucleus, where it also decussates. So if you have a lesion that's below the red nucleus, you get upper limb extension because you are cutting off the corticospinal and cerebrospinal fibers, and therefore it prevents the red nucleus from causing upper limb flexion. On the other hand, if you get a lesion above the red nucleus, you're preventing the inhibitory tone of the red nucleus, which then allows you to activate upper limb flexor. So you get this upper limb flexion, which is seen in the bottom image, and that's called decorticate posturing. And in both of these instances, in both of these types of lesions, you get lower limb extension because you disrupt the lateral cortical spinal tract, and there's a bias towards extension in the lower limbs. I'm actually not too sure, like specifically why vestibulospinal and reticulospinal will be like the action will be more than the corticospinal, but it just happens that I don't think you have to know that, but it's basically, if you remember like what the pictures look like, that's how the two postures look like. Now we'll move on to cortical control of motor activity. Again, if you have any questions, just put them in the chat, or you can unmute yourself. So cortical control of motor activity. Obviously we'll start with like the motor cortex, and actually there are many different parts of the brain, like or like parts of the cortex that are involved in voluntary movement. So like nearly the entire neocortex is involved if you think about it in terms of like communication between the different areas of the brain, and like planning and then programming and then executing the movement. If you think of those different steps, you have like many different areas that are involved, but the main kind of area that we associate with movement itself, or with like producing movement, is the primary motor cortex, which is also called M1, which is in Brodmann area 4 on the precentral gyrus. And this is first discovered, or I don't know if it's first discovered, but this was like shown by Wilder Penfield with his experiments, where he used electrodes to stimulate different areas of the cortex in epileptic patients. And when he stimulated area 4, it was able to produce a twitch of the contralateral muscles. So that's how they kind of localized motor function to this area of the brain. And the parts of the brain that provide input into M1 are the SMA, the premotor and somatosensory cortices, and the ventral anterior and ventrolateral thalamus. And those are also having inputs from the cerebellum and basal ganglia. And then the outputs from the motor cortex, from the primary motor cortex, are to like the cortical spinal tract, the cortical bulbar, cranial nerve nuclei, and basically like everything we talked about before. So these are a few useful diagrams just to show the anatomy and where area 4 is and where the precentral gyrus is. So it also shows like that the SMA, which is the supplementary motor cortex, and the premotor cortex are in area 6. So just beside or just next to M1, and they're closely related in function. So these are the different areas that are involved in motor control. And well, in terms of like prefrontal and posterior parietal, those are more so like the kind of functions they're not like directly involved, but then they signal to the motor cortex, if you know what I mean. So first, like prefrontal cortex, it's more involved in like kind of like higher control, so decisions or planning, motivation, stuff like that. So if you guys remember from like your lectures, Phineas Gage, so the person who has like I think an iron rod through his head or something, and it affected the prefrontal cortex, and therefore he lost like inhibition of his behavior, and also like lost inhibition of like some of his movement. So like prefrontal cortex is actually involved in like many different functions. It's definitely not just involved in motor control, but when you think of it in terms of like voluntary movement, and planning of movement, like what am I going to do next? It involves the prefrontal cortex, like intentional movement. And then the posterior parietal cortex, it's more involved in like proprioception and integration of like different signals. And for this, you can get something called neglect, which I think you learned in like your other lectures as well. So if you have damage to the posterior parietal cortex, you can get neglect. But I won't talk about it in detail because I'm just going to focus more on like the motor part of things for this lecture. So this supplementary motor cortex, which I mentioned earlier, it has inputs from the basal ganglia and it's in medial area 6. So it's involved more in like planning of spontaneous environmental movements, as well as like internally generated and guided movements and sequencing of actions. So planning and sequencing. And then the premotor cortex, which is the lateral area 6, and has inputs from cerebellum. It helps with the sensory guidance of movements and postural adjustments. And the motor cortex, as we mentioned, is control voluntary movements, especially like fine control of movement. So we'll talk a bit about like the important cortical structures and then we'll move on. But I'm not going to go into much, I'm not going to dwell on this too much. So the premotor cortex has inputs from prefrontal, posterior parietal, and cerebellum, and it has outputs to the motor cortex, prefrontal cortex, blah blah. And I don't think you have to know these like specifically in detail. I think it's more important to remember like the division of function of like the different parts of the cortex. Yep. And then there's a supplementary motor cortex, which is more in terms of like sequencing and planning. And when you have any lesions in the supplementary motor cortex, you can get loss of bimanual coordination. And by that I mean like you can like normally bimanual movements means like movements that require both hands to do. So like coordinating movements in both hands. And when you have lesions in this part of the brain, you basically lose that coordination. And you hit akinetic rhesism, as well as locked-in syndrome. So it means that like it's not just involved in motor control, but it has a very important role in motor control. In this diagram I took from one of our lectures, which shows basically like the connections between the different parts of the brain as well as their functions, as well as like the connection with the sensory system. So it's quite a complex kind of like it's quite a complex organization, but you can think of it in terms like of the different steps of first you have to have the motivation, which is like in the limbic areas, also partly in like the prefrontal cortex, and then planning, which is like in the premotor areas, and then programming, which is the motor cortex, and finally integration in the brainstem, and the execution in the spinal cord and the muscles. So if you think about it in this way, I think it's easier to understand what are like the main functions of each part of the motor system. Okay. Now I'll move on to the basal ganglia. Again, like you can, if you have any questions, just type them in chat or stop me. Or if I'm going too fast or too slow. So the basal ganglia is an extrapyramidal structure and it's subcortical. It's deep in the telencephalon, which you don't really have to remember that, but you just have to be able to identify it on like an image or a diagram, for example, because you can ask. Sometimes they have questions in the exam where they give you like a sagittal scan of the brain and they label different structures or coronal, and they label different structures and they ask you like what is the function of structure 1 or something like that. And if you don't, if you can't even identify like what structure 1 is, then you can't even answer the question, even if you know like even if you would know it, like even if you knew the function, you wouldn't be able to answer the question. And therefore that's why like neuroanatomy is quite important. So basal ganglia, it's this red thing in the diagram on the right. and it had input from the cerebral cortex, so especially the frontal, prefrontal, and parietal, and it outputs to the ventral, lateral, and ventral into the thalamus. And that's how it then connects from the VR and VA thalamus. It then connects to the primary motor cortex. So it forms a loop. You have first the cortex, and then to the basal ganglia, and then to the thalamus, and then to the cortex, which forms a loop. And I've tried to draw it in the diagram, but like, yeah. And the function is selection, initiation, of voluntary movements, as well as internally generated goal-driven motor programs. It's just something that you just have to remember. So these are the components of the basal ganglia, and you do have to remember all of them, and you also have to be able to label them on like a scan or on a diagram in this kind of view, and that's why I put this. Sorry. That's why I put this image here, because I thought it's quite helpful to visualize where they all are. And if you did like your practicals and everything, I think they taught you how to identify like the different structures. So the striatum is composed of two parts, the chordae and the putamen, and then you have the globus pallidus, external and internal. Then you have the subthalamic nucleus, and finally substantia nigra, pars capitis, and pars reticulatum. So now we move on to the direct and indirect pathways, and it looks a bit sorry, this slide I think is not very helpful, whereas like I actually drew a diagram and which kind of explains the two pathways. So the direct pathway is the one that's like directly from the that's directly from the cortex to the putamen to the SNR / the globus pallidus internus, and then it helps to release the VA and VR thalamus cell-term inhibition, and therefore it boosts the motor activity, like it increases motor activity. Whereas the indirect pathway antagonizes movement because it inhibits this thalamocortical relay, and it increases the activity of the subthalamic nucleus, which then increases the activity of the globus pallidus internus, and which has an inhibitory effect on the thalamus. Yeah. So in general, the direct pathway helps to select motor actions, whereas the indirect pathway suppresses competing and inappropriate motor programs. And I found, so when I was learning this, I found this diagram quite helpful, although it's a bit complicated. But then if you remember this diagram, then you remember like where everything is and like what the function of each is. I think it's even if you can't like remember everything, you should remember like which structures have like an inhibitory / an excitatory effect on which structures. So how they're connected. Especially like if you want to write an essay that involves the basal ganglia, then you can like draw a diagram instead of like having to write everything out. Just draw a diagram. And the important things to remember is that the important things to remember is that the direct pathway is straight from the striatum to the SNR / GPI. So just remember that it's shorter. That's why it's called direct. And these mostly use D1 dopaminergic neurons, whereas the indirect pathway involves D2 dopaminergic neurons as well. Yeah. And the inhibitory effect then is the output to the thalamus. Okay. I will move on. I know this is like, but you can go back and look at this in your own time. So can someone type in the chat? Sorry, I wanted it to be a bit more interactive, but I know it's like too much information. So can someone type in the chat what are some conditions that you can see when the basal ganglia is damaged? Sorry, I wasn't looking at the chat. Okay. Yeah. Yep, good. So a lot of like movement disorders, and then two main ones that you need to know are Parkinson's and Huntington's. there are also, so you can also get like drug-induced Parkinsonism, it's like MPTP, and you can also get like this thing called bolism. I'm not sure if I'm saying it correctly, or hemibolism, which is like one-sided, and that is when the STN is damaged. So I've written down like which structures are damaged in which disorders because they're important in terms of understanding what are like the dysfunction, like what are the dysfunctional effects in these different conditions. And besides Parkinson's and Huntington's, you can also get like multiple system atrophy or Tourette syndrome or just dystonias, like other types of dystonias. And in terms of like the different symptoms, so these are like a list of different symptoms that can occur in these different conditions. And I've written down some of the explanations because some of them are a bit confusing or they sound a bit similar. I think the main ones that you should know are akinesia, which means like no movement, or bradykinesia, which means slowness of movement, and then resting tremor, which means like tremor at rest. Chorea are involuntary, irregular, unpredictable movements, and they're often described as being dance-like. So it looks like the patient is like fidgeting or dancing. And if you don't know what it is, you can look up some videos on it and then you'll understand what it is. Then you have a few others that are quite similar, and I don't think you have to differentiate like all of them. You just have to know the main symptoms, and I think Parkinson's and Huntington's are the ones in your syllabus. And Bullismus is a repetitive but constantly varying large amplitude involuntary movements of the limbs. So it's more focused on the limbs, and repetitive is the difference between Bullismus and chorea. So whereas chorea is like random and unpredictable, Bullismus is repetitive. That's the main difference. Right, so now we'll move on to talk about the different disorders in a bit more detail. So can someone tell me what are the symptoms of Parkinson's? Like any symptom? Yes, resting tremor, very good. Yes, rigidity. Yes, so bradykinesia. Okay, and there's one more that's very important. Yeah, shuffling gait, or actually there's one more that's postural instability. So the way that I remembered it in the past, oh sorry, let's talk about symptoms first. The way that I remember in the past, we were taught TRAP, but then I added S for the shuffling gait. Basically, like tremor, T is for tremor, but resting tremor. So maybe you remember it by R, but I remember it as T because of the tremor. And then rigidity, akinesia, bradykinesia, postural instability, and shuffling gait. Or you can create your own like mnemonic, which is probably better than this, but that's just how I remembered it. And also besides movement symptoms, you also get problems with sleep, cognition, and memory in Parkinson's. And Parkinson's is caused by degeneration of SNC, so nigrostriatal neurons. And because of the depletion in dopamine, you get hypokinesia, which means like less movement. And it's the second most common neurodegenerative disease, however. And so the pathology is Lewy bodies containing alpha-synuclein aggregates. And the main drug treatment is levodopa or L-dopa plus carbidopa. So carbidopa is a peripheral decarboxylase inhibitor. It's because the L-dopa can't pass through dopamine can't pass through the blood-brain barrier, so you cannot just give the patient dopamine. You have to give them L-dopa, which is a dopamine precursor, so it can get through the blood-brain barrier, and then it's converted to dopamine, and which then exerts the effects, like replacing dopamine in the brain. There's some problems with L-dopa which involve like on-off effects and gait freezing, so the patient can actually get like sometimes like just completely freezing, and sometimes like overly like too much movement, and dyskinesia, which is like irregular involuntary movements. Some side effects. And other therapies would be deep brain stimulation, so deep brain stimulation of the STN, as well as some MAO or COMT inhibitors and stem cell transplantation. But you don't have to know these in detail. This is just a pathway showing that L-DOPA is converted to dopamine by DOPA decarboxylase. And that's why you need a decarboxylase inhibitor, because it prevents breakdown of L-DOPA in the periphery so that it can get into the brain. Like it can cross the blood-brain barrier and get into the brain before it's converted to dopamine. But you don't want it to be converted to dopamine before it gets to the brain. Fine. And then MPTP, which was one of there were some outbreaks of Parkinsonian symptoms in drug users in Maryland, California in the 1970s and 1980s. And this is how they discovered that there's this chemical compound that causes a disease that resembles Parkinson's. And it's because it's converted to MPP plus, which is a neurotoxin, and it binds dopamine transporters and causes death of SN dopaminergic neurons. So it's interesting because that led to also the development of some of the animal models of Parkinson's, but MPTP is not the only one. So there are other neurotoxins that you can use to model Parkinson's, which you don't actually have to know about, but if you want to write in your essay, you can write in an essay. So you have 6-OHDA, you have agrochemicals, as well as you can overexpress mutations because there's some known mutations that are associated with Parkinson's. So SNCA, which is the alpha-synuclein gene, and then LOCK2 and GBA, etc. So these are just 3 different ways that they make animal models of Parkinson's to study Parkinson's, but they're not perfect because they don't completely replicate the disease. But you can write about it in your essay. Okay, then we have Huntington's. So can someone tell me what is a symptom of Huntington's in the chat? It's from the list that we mentioned earlier. Yeah, so it's hyperkinetic. Yeah, chorea. So you do very good. So you get excess movement. So you just have to contrast it with Parkinson's, because instead of affecting dopaminergic neurons, they affect the GABA neurons. And because GABA is inhibitory, so if the neurons degenerates, then you get excess movement. Yeah, versus dopamine, which is the opposite. And they affect striatal pallidal neurons, which are the neurons between the striatum and the globus pallidus. And you have hyperkinesia. So chorea, dyskinesia, dystonia, and also some rigidity and cognitive impairment as well. And the gene that is involved is the the HTT gene encoding Huntington protein, and it's the CAG trinucleotide repeat expansion, which I think all of you know. And this causes accumulation of the protein, which disrupts normal function of neurons. And this is hereditary. So whereas Parkinson's is in Parkinson's, there's a genetic / familial or sporadic or environmental component. Huntington's is just hereditary. So you have to inherit the abnormal gene in order to get Huntington's. So the treatment is anti-dopaminergics. And the thing is that these medications only treat the symptoms and there's no cure, and they also don't reverse the course of the disease. So it progressively gets worse even with these medications, but these medications just help to control the symptoms and improve the quality of life for the patient. Finally, okay, not finally, but next we'll move on to the cerebellum. And I don't think I will finish, but as I said, you'll get the slides if you fill in the feedback or if you're happy to stay a bit longer. But if you need to leave, you can leave as well, it's fine. So the cerebellum is this structure where we talk about being inferior and posterior in the brain, and it's inferior to the occipital and temporal lobes. It takes up 10% of the brain volume by half of all neurons, which is why it has such an important function. Mainly coordination, calibration, learning, and automation of skilled movements. So an important differentiation between the cerebellum and the basal ganglia, I think, is that the cerebellum is more involved in motor learning. And also it has some functions in balance as well. Yeah. So I've written some notes here, but I'm not going to go through all of them. One thing to remember is that it doesn't have any direct output to the spinal cord. So it only projects to, the only outputs project to the deep cerebral nuclei or the motor cortex, which then modulate the brainstem motor areas. So it doesn't have any direct projections to the spinal cord. in the interest of time, I will stop asking questions and just move on. So these are the three. What's the function of the hyperdirect pathway? Sorry, I missed that. I'll come back to your question at the end if that's all right. So this in the cerebellum, there are three parts of cerebellum, and I made this table for myself when I was revising. Because it's actually not like the functions are not exclusive, but it just helps to like differentiate them a bit. And you have to, unfortunately, you have to like remember the inputs and outputs as like part of your neuroanatomy and also as part of like the like as part of this topic. So how I kind of remember it is the three different parts they project different nuclei, and it might be easier to look at it in a diagram form, which is in an image form, which is like this. So this is from one of our lectures as well, I think. So you have the fastidial interposed and dentate nuclei, and that's where they output to respectively. And then I always found it very confusing because there's a superior cerebellar peduncle, and then there's an inferior and middle cerebellar peduncle as well. But I don't think you have to, well, I think it's as long as you know like which fibers pass through which peduncle, I think it's fine. So the superior ones are like the fibers to like from like the fastidial interposed and dentate nuclei to the vestibular nuclei, for example. And then you have the pontine mossy fibers, which go through the middle cerebellar peduncle. And then you have the climbing fibers from the inferior olive, which go through the inferior cerebellar peduncle. And then I, again, like this is my hand-drawn diagram because it just helps me when I make it a bit simpler for myself. Because the site architecture is a bit more like I would say like a bit more complex than this, but then this is like just simplified already. I think the main things you need to know are what are the layers and which one is like from which one's inner, which one's middle, which one's outer. So in the inner layer is a granule cell layer, and then Purkinje cell layer is the middle layer, and then molecular layer is the outer layer. So the molecular layer contains the parallel fibers. And then you have three types of interneurons, which all of which are inhibitory, so you use GABA, basket cells, stellate cells, and Golgi cells. And I don't recommend learning like the details of each, but yeah, you probably don't have to remember what are the differences. Or I'm not too sure for myself now either. Like I don't actually remember them. I think what I found helpful was more to remember where each like nuclei or where each like each of the fibers project to. Yeah, where each set of fibers project to. And there's a lot more that I can talk about for the cerebellum, but then I was aware that I wouldn't have time to talk about all of the different parts, all of the different fibers. So can someone tell me what are some symptoms you would get if the cerebellum is damaged? Like any symptom? Yeah, so you get intention tremor, which is in contrast to the basal ganglia where you get resting tremor. And yes, loss of balance is a very important symptom. Okay, so I'll just move on. And I'm aware it's 8, so if you need to leave, you can just leave. Or if you have any questions, you can drop them in the chat now, and I'll either answer them or I'll put them like in the last slide because I'm aware it's quite late and I don't want to keep you if you have something else to do. But I would just finish this for those of you who are okay with staying for a bit longer. Okay, so yes, you have incoordination of fine movement and ataxia. I would say these two, the first two are like the most important, like loss of coordination of fine movement and ataxia. Ataxia is describing like a staggering wide-based gait, which is related to like loss of balance as well and posture instability. And the tremor is an intention tremor, very good. It helps to differentiate from basal ganglia, which usually presents with like a resting tremor and Parkinson's. And then you can also have postural tremor, which is when you're just like in a fixed position. And then there are a few others which describe like the incoordination of movements, which is like dysmetria, dysdiadochokinesia, asynergia, hypotonia, nystagmus, which is like an eye, like involuntary eye movements, which again differentiates it from like basal ganglia, and dysarthria, which is slurred speech or difficulty speaking, which again like differentiates it from other types of lesions. So I think this is less important because it's actually quite hard in real life to differentiate between the locations of lesions, and most of the time you get the lesion in you can have damage to more than one part of the cerebellum. But this was just something that I think this is from like a textbook rather than something you have to know per se. So I'll skip this slide and I'll just go through all of this because we're running out of time. So for cerebellar pathology, I listed some examples. So I think in your syllabus they talk about atax, like hereditary ataxias. So these are caused by genetic mutations. You can have spinal cerebellar ataxia or Friedreich's ataxia, and both of them are caused by like a genetic pathology. But if but you don't have to know. I don't think you have to know the genetics in detail unless you want to write it like as a. I think it's more right hand side in terms of like the specifics. But it's good to know like what are some conditions that can be caused when the cerebellum is damaged. And an interesting one would be CCAS or cerebellar cognitive affective syndrome. It's interesting because there's a cognitive component as well. So it kind of highlights the connection between the cerebellum and other like other functions or like other circuitry in the brain that is not just it's not just involved in motor function, but also like learning as well. And yeah, problems with like executive and visual spatial abilities. So some other causes of cerebellar damage include like alcohol. So you can get like alcoholic cerebellar symptoms, and also tumors or neurodevelopmental dysfunctions. So it's vascular damage, so like stroke, trauma, and a few other things. So this is just a list of examples which you can refer back to. And the last section, which I will speed through, is eye movements and pupillary reflexes. So these are the actual of the muscles, which like all of you know about. And I found it useful to think of it as like to remember it from a diagram and where the muscles are, plus what movements they cause. And in terms of the innervation, the mnemonic that's commonly used is LR6SO4R3, which tells you like which muscles are innervated by which nerves. So all of them are innervated by the oculomotor nerve, which is the third cranial nerve, except for the lateral rectus and the superior oblique, which are innervated by the abducens, which is cranial nerve 6, and the trochlear, which is cranial nerve 4, respectively. Fine, so eye movements. I don't think they're tested as much as the others, so I will actually speak through them and you can come back and look at them on your own. So there are 4 types of eye movements in your syllabus, which I've listed here, and their definitions. So I think smooth pursuit is good to know because it's basically where you like keep a moving object in focus by having like these slower tracking movements of the eyes. And then everything else I think you can look at on your own. Honestly, I don't think I revised eye movements as much. I think the more important ones are like the eye muscles and like the lesions to the nerves can cause like what can be caused by lesions of the nerves. I'll skip this slide and I'll come back to that time. Okay, so can someone tell me what they can see in the image on the left? Like what is abnormal about the eyes for the left image? You can type in the chat. Or if you already know the lesion, you can also just tell me what you think the lesion is. Like which nerve is affected. Okay, so it's not trochlea, although that's a good thought. Anyone else? Or any other guesses? Um, well, we'll just do the left image. Actually, the left is harder. Yeah, so the oculomotor nerve is the left one. What about the right image? The right is easier, I think. The right image. Which nerve do you think is affected? So in the right image, the right eye is pointing like it's abducted. Yeah, so the abducens is affected. Okay. Um, so the way you kind of go about it is um to think of like the consequences of the different lesions. And actually there are images online as well that um make it easier. Like they show you what the different lesions look like. So just go and search about on your own because I didn't put it in. But there are nice like images online that show you the consequences of each lesion. Um, so oculomotor is classified down and out, which is the one that I showed you earlier on the left. This is called down and out, means like it's lateral and inferior. And it's harder to tell, it's harder to remember because of so many different muscles are involved by the oculomotor. But if you just remember down and out, then you can recognize the lesion. Whereas trochlea, you'll have up and out instead. And you may get compensation by the patient tilting their head away from the affected side. And abducens, the eyes are ducted, so you cannot up, abduct. Um, okay, so finally, there's something that I want to talk about, which is the Horner's syndrome. Um, it's classically a triad of ptosis, which is drooping of the upper eyelid, miosis, and hydrosis. Miosis is pupil constriction, and hydrosis is abdominal starting. And this is caused by damage to the sympathetic trunk in the neck. But what it causes is basically it causes like the eye like abnormalities in the eye. It looks like the image on the right. But because it's not the focus of this part, so I'll just skip through it. And that's the end. And I did have some questions, but we won't go through them in the interest of time. But they are in the slides and they are from like past specimen papers. So you can look at them on your own and just test yourself after this. Yeah. So I'll stop talking for now. And does anyone have any questions? Okay. I'll address the one that someone asked earlier. Oh yes, yeah, I can put the link in the chat. Sorry, just give me a moment. So this is the feedback form. And I'll address the question that someone asked earlier. What's the function of the hyperdirect pathway? So let me just go back to that. I think so the hyperdirect pathway is actually for us at least, it was on the right-hand side of the syllabus. So you don't actually have to know it, like it's a bit extra. Um yeah, so sorry, let me look at the questions. Okay, okay, to address the other question, so like the hyperdirect pathway, I think you don't really have to know. It's just a pathway from the cortex directly to the STN. And it helps with the facilitation of movement because it stimulates GABA neurons in the globus pallidus and the substantia nigra, which then inhibit neurons in the thalamus. Um, And I'm actually not too sure of the function myself, because I think it's quite an extra information kind of thing. Sorry, let me look at the other questions. What is the function of the pathway through the cerebellum? Is it mossy to output nucleus via the granule Purkinje cells inhibiting movement? So not exactly. So sorry. Yeah, not exactly. So it's not as I think it's not as simple as the mossy fibers facilitating and the granule Purkinje cells inhibiting movement. Although, let me double check. Let me stop sharing from it. So actually the main difference between like so it's more so that the Purkinje neurons haven't, so you're right that the mossy fiber input has like it has an stimulatory effect on the deep nucleus neurons. So yes, in a way it does facilitate like their motor function, whereas the Purkinje neurons are inhibitory, so they inhibit the deep nucleus neurons. Yeah, that's the main difference. So in a way, yes. Okay, there's a question. Can you say anything about the different models of motor disease? Firing rate, firing pattern dynamic. So I'm not sure I fully understood your question. From Dominic. What do you mean by models of motor disease? Okay, I'll answer another question first. If you could clarify what you meant by like models of motor disease. Okay, sorry. So in a cerebellum versus basal ganglia assay, let me find my. So I think I did have something along those lines. Let me try to find it. So I think what I would do, like in terms of like comparing the cerebellum and basal ganglia in an essay, is I would like split it into different sections, so like have different headings. I guess you could either start with anatomy or function. So you can start with like what is the main function of each. And so you can say that the main function of the basal ganglia is more selection and initiation of voluntary movements, whereas the cerebellum is more involved in like coordination and motor learning and balance. And then you can move on to say, so what's the anatomy? So in the basal ganglia, or like where it is in the brain, and then what are the components. So the basal ganglia contains like the striatum, the STN, the globus pallidus, etc. And then whereas the cerebellum, it has three parts, the cerebrospinal and vestibulocerebellum. And then yeah, you can compare like the anatomy. Then in terms of like the kind of like cells that are involved or like the cytoarchitecture, you can compare the basal ganglia being like D1 and D2 dopaminergic neurons. And you can like draw like the circuit or something. And the cerebellum, you can talk about the inhibitory interneurons, which are the basket, Golgi and stellate cells. And also you can talk about like the mossy fibers and the mossy fibers, climbing fibers, and parallel fibers, as well as the three cell layers that we talked about, so like the anatomy side. And then I would compare in terms of like um I guess like in terms of function, if you were to write an essay, you can compare like the models or theories as to like how their function, like how the function works. So in the basal ganglia, you can talk about the um you can talk about the traditional model of like the two populations of neurons being like the direct and the indirect pathways, as well as like the D1 versus like D2 dopaminergic neurons. And they did some like experiments in I think transgenic mice where they stimulated like the two populations of neurons to differentiate them. Um, and then you can also talk about the action selection model in the basal ganglia. And there's another model called the rate model as well. And in the I think in the cerebellum, the main one would be the Marr-Elbas-Ito model or theory, which talks about like the climbing fibers from the inferior olive, relaying messages of motor error to the Purkinje cells. So that's one of like the models of how the cerebellum achieves motor learning. And there's also a model of like LTP and LTD, and that you can also talk about that, like when you compare like the models or theories as to like how they achieve the function. And I think, oh, and finally, then you can talk about how like the lesions or pathologies differ in the cerebellum versus basal ganglia, and that's how you get your like clinical relevance marks as well. So talk about like Parkinson's and Huntington's in the basal ganglia, and then in the cerebellum you can choose different ones to talk about like ataxia, sorry, like spinocerebellar ataxia and etc. Um, yeah, so to summarize, I would kind of split them into sections, so like anatomy and then like cellular circuitry or like microcircuitry, and then function, and then the theories as to their function, and finally the pathology as well as like the effects of lesions. Yeah, but it depends on the question. Are there any other questions? So there's a question about LTP and LTD. And so there's nothing, so I would say that actually that is more for the cerebellum than the basal ganglia. So LTP and LTD is kind of it describes how the cerebellum learn, like how motor learning occurs in the cerebellum. And to be honest, you don't need to know much about, like you don't need to know in detail. But then again, it depends on what the question is. So if the question is about like motor learning specifically, then you can talk about LTP, LTD. Um, and what I would suggest, so there are a few good textbooks that like the medical school that is in the reading list, and I used the textbook to like look up additional info. But we also had in our lectures, so there is, I think there was one there's something called the BCM theory, which is like the LTD part, and then in the L I think in the LTP So the LTP is, we can talk about like the NMDA receptors as well as like, but I don't think you have to go into detail unless the question is specifically about motor learning. Yeah. And like if I can send you like some of my notes if you want. Oh, so the rate model and the action selection model. Okay, good question. So again, like I would recommend looking at some textbooks for a better explanation. But from what I understood, the rate model um is that the basal ganglia processes cortical input through parallel pathways from the striatum through to the output nuclei and then feeds it back to the cortex via thalamic relay. And the increase or decrease in firing rate of the different basal ganglia nuclei is thought to underlie behavior. So it's so it's a so it's a model that suggests that like it's the firing rate of the different nuclei that influences behavior. Yeah, but I don't think it's that important. It's just something that you can like refer to if you want to get extra marks. And then the action selection model is when so it suggests that different neural networks or like different groups of neurons in the basal ganglia pathway, they activate or inhibit different motor programs. So like they activate or inhibit individual motor programs. Yeah. But if you want more like in-depth explanation, you can check like some of the textbooks or you can just like you can search for it like online as well. Yeah, sorry, I don't think that was a very good explanation, but thank you for asking the question. Are there any other questions? Okay, I'm not seeing any other questions. So again, if you need to go, you can feel free to leave. And please fill in the feedback form to get the slides because a lot of the info are in the slides as well. And thank you so much, everyone, for coming today. I hope it was vaguely useful.
Thank you very much. That was fantastic. Yeah, I will send you the feedback later if you'd like. And yeah, that's it.
Okay, yeah, that would be
So,
helpful. Thank you.
yeah, thank you.
Yeah.
Sorry, do you have any questions?
Yeah, no, I was just wondering, do I have to send the slides or should I just upload the slides and then someone else will send them?
I will send them if you're able to upload them. I've tried to change the setting. Oh, sorry, I will stop recording.